Hey, DNA. It's time for another episode of All Access DNA, and I'm your host, Kate Wilson. Today, we are talking about hereditary cancer care for transgender and gender diverse people. Our guest is Dr. Mittendorf, they, them, an interdisciplinary scientist whose current research focuses on translational genomics and cancer care delivery, especially as it impacts populations with reduced access to care. For a quick recap, hereditary cancer refers to cancers that are due to an inherited gene change. This means someone with hereditary cancer can be at increased risk for certain cancers over the general population and may have inherited this risk from one parent. So, individuals with hereditary cancer may have a family history, see cancers at younger ages in their family, or have other red flags. Let's get started. Thank you so much, Dr. Mittendorf, for joining us today.
Thank you for having me. I'm glad to be here.
Let's start with the first question. Why is it important to discuss hereditary cancer in context of transgender and gender diverse individuals?
So first, let's just start with how gender affirming care affects trans folks and their cancer risk overall, not just for inherited cancer. So in trans feminine folk who are taking estrogen or progesterone or both, breast cancer risk is much higher than other people who may have been assigned male at birth, but who are cisgender or are not undergoing any type of transition by choice, though it's probably less than that of cisgender women who have a more lifetime exposure to estrogen, although, of course, now people are able to access these hormones earlier in their care. Also, for trans femme folks, usually the prostate state is kept even if there is bottom surgery. So screening for both types of cancers, prostate cancer, breast cancer, is important in trans feminine folks. And that screening becomes especially important if they have a family history or a genetic risk, because breast cancer and prostate cancer are both tied to hereditary pathogenic variants or variants that can cause cancer that are passed down through families. And both prostate and breast cancers are in the same types of syndromes. So cancer syndromes have more than one cancer that can be caused by those variants, and prostate and breast are sometimes even caused by the same genetic variant in a person. So, unfortunately, to date, no study has been well controlled for all of the different types of factors that can influence risk when they are taking any type or having any type of gender affirming care. So then they don't control well for the amount of time someone contributes to the model. So if you are in a longitudinal study for 2 years versus somebody who might have 4 years of data to contribute to the study, it's different. Also, they don't control well for the types and doses of hormones people have taken in these studies yet, or the age at observation when they are taking a sneak peek. If it's a cross-sectional study, that means like a snapshot in time study, or the age at which someone started hormones. As I just alluded to, someone might start hormones younger and therefore have a longer time that they are exposed to estrogen, and so have a longer time of having breast tissue that's exposed to estrogen and progesterone, and, therefore have a higher risk of breast cancer. So a systematic review of other studies found that risk for trans women may be as high as that of 23 times that of cisgender men, albeit about a third of that of cisgender women. It's still an appreciable risk, though, as I mentioned, that study is basically looking at a bunch of other studies that were done, and they didn't even control for many of these other measures, and they didn't even measure a lot of these other things. So it's not like the systematic review could control for them either, because they weren't even measured in the original studies. So like length of time on hormones wasn't even reported for a lot of these studies. So similarly, in transmasculine folk, gender affirming care can affect their cancer risks. So top surgery leaves tissue behind. Transmasculine folks often get a type of surgery that gives them a masculine chest shape. So it removes most, but not all, of the breast tissue. And the tissue left behind can still get cancer because it's not the same as the types of surgery some people have to reduce cancer risk. In that type of surgery, the surgeon carefully takes out all of the cancer tissue between the basically epithelium and the chest muscle wall. So they take out all the breast tissue, and especially all of the lobular tissue, which is more at risk. In terms of testosterone, we don't really know how it contributes. There have been a few studies that say that it reduces risk. There's been a couple of studies that have found an equivocal risk. And then there's been a couple of studies that found potentially an increase in risk or an increase in risk in certain types of breast cancers. So we just don't really have enough data to say about testosterone use. But in terms of that surgery, we do know that there is definitely tissue that can get cancer. And that same systematic review I mentioned before found that trans men may be up to as high as 60 times the risk of cisgender men. So that's, I think, a quite appreciable risk that differentiates them from cisgender men, albeit they are a little less than half of that of cisgender women. Again, these studies that are looking at this, they're snapshot studies or they're retrospective studies. They're not necessarily getting all the types of data that we might want, like what age they had their top surgery, you know, whether or not they had taken birth control or other types of estrogen, what the density of their tissue was, because we know that's actually factored into some types of risk scores that we do. They don't necessarily get data on how long people were on testosterone. So even some of those studies that I've told you that have had mixed outcomes in terms of testosterone, we just don't really have enough information to say about testosterone at this point in time.
And it sounds like knowing hereditary risk would impact potential choices or surgeries that somebody who is transgender would want to do. How does the hereditary risk affect these folks?
Yeah, so hereditary cancer risk is important for everyone to learn about, not just transgender folk, of course. And guidelines say, and I'm sure you've covered this on the podcast, but that guidelines say that primary care providers are supposed to screen for your family history of certain cancers, and they should be referring individuals with worrisome family history to genetics, usually genetic counseling. Unfortunately, primary care folks are under-resourced and have a lot to cover in very short appointment times given today's healthcare ecosystems. So even folks who don't necessarily have additional special considerations related to surgeries and gender affirming care, this type of referral isn't being generated as often as it should be. But since trans folks are making these really critical care decisions, to make a really informed decision, say, about, types and amounts of hormones to go on in somebody who is a trans woman, say, for instance, who has a hereditary risk of breast cancer, they may make different informed choices with their doctors. It's not like there's one hormone prescription plan that works for everyone. So doctors are always making small adjustments with their patients, and that can be part of an informed discussion. It's not to say that they should be prevented from getting access to those types of hormones, but they should be given all of the information that we can give them about their risks so they can make informed choice. And then for transmasculine folks like myself, when you're making a decision about top surgery, it's possible that even knowing you had a genetic risk, you may want a standard top surgery because the aesthetic is different than somebody who has a full cancer risk reducing mastectomy. But people who are given this information, and in a recent study, Cortina group assessed this, and many people, not knowing their genetic risk, but just knowing a general risk of breast cancer, chose a risk-reducing mastectomy, actually, not even having genetic testing or anything like that. They found that risk information when people had risk information in their own informed surgery choice discussion, they often chose a risk-reducing mastectomy rather than a standard top surgery. So I think that what this means is we need to be sure to be giving people a full family risk assessment and placing referrals to genetic counseling as part of their gender affirming care so that they can be having really good conversations with their doctor about what they want. Because if you get breast cancer and you have chest dysphoria, that could be even more dysphoric. And we've heard from cisgender men that that's true.
And you talk about hormones a bit. So I wanted to see if you could tell us a bit more about gender identity and hormone use. Like, how does that really impact the risk for cancer?
Yeah, I think I mentioned before when I was going off our list of questions a little bit early, I jumped the gun and told you, that we don't really have enough data in terms of testosterone and how it may affect use just because we just don't have information. I mean, some of the testosterone studies, they don't even include whether or not somebody had top surgery in the studies.
Mhm.
So we know top surgery likely reduces risk, and everything that we have in the evidence suggests that it reduces but does not eliminate risk compared to cisgender women or people who are transmasculine but have not had top surgery. But
Mhm.
what we don't know is how testosterone influences risk just because the studies are so sparse and they're just so poorly adjusted for these other factors. Because I
Mhm.
think in a lot of the cases, we just don't have them. And I actually think, and I don't think when we talked about having this, I had thought about this yet, but with the erasure of a lot of public data sets from losing out on types of data related to gender identity information, to sex at birth information, and collecting like one variable to rule them all and just having it
Right.
be a binary variable is actually going to be a huge detriment to cisgender and transgender and intersex folks. All these types of folks who, we're not getting good distinctions about hormone usage, and all of this data is just going to get mixed together in really funny ways, and it's not going to be good for anybody.
Right.
That's really frustrating to me as a scientist who wants to do personalized risk for people, right? Like, I want us to be able to, in a perfect world, give you a really confident answer on like what your lifetime chance is of developing cancer based on all kinds of factors, like whether or not you smoke and whether or not you know,
Well, and that's precision medicine. That's the
that's
promise of
precision
personalized
medicine.
medicine. Yeah.
Totally. And I think it's a huge detriment to everyone. And in fact, I had this paper in draft about this related to like what variables we could collect instead before all of this went down. And it's just sitting on my shelf right now because I don't feel like it's safe to advocate that we collect all those variables in the current political climate. But at the same time, there are so many people who would benefit from it. I mean, you have women who use small amounts of testosterone, cisgender women who use small amounts of testosterone for libido, right? Like, these things may be important to know: dosage, duration, time, method of administration, whether it's dermally or through an injection, or, lots of means of administering these hormones. So
Tell me a bit more about how people see statements from doctors as absolutes, because I think you had some research on that as well.
this is actually a very important topic to talk about. Part of it may be that doctors aren't fully informed, and some of this is research that hasn't quite been published yet. Although my student Kai, actually, him and I was Kim was primary mentor, Kim Zahowski, and then I was a sort of on their capstone committee mentor of Kai Blumen, and they presented at NSGC in the platform presentations on some of their work. But we've heard this now from providers in a study from KEMS that's forthcoming, and from patients in a study from Kai. And Kim spoke about this in her JEMF talk. If you were at NSGC and saw this talk, or if you just haven't accessed the recording yet, I know that one when it was up. Providers shared stories about how they had patients where the surgeon had told the patient that they were at no further risk of breast cancer, and because the surgeon typically doing this is not a cancer surgeon, they're a plastic surgeon. And they had told the patient that they didn't need to worry about breast cancer anymore, or at least the patient and maybe even the provider had interpreted that to be the recommendation. And then the patient got cancer. And Kim has one example of a provider interview, I think, where the patient actually tragically died of breast cancer because it was caught too late. And so obviously that's the extreme outcome, but there are lots of in between extreme outcomes of just the morbidity that catching cancer late can cause, right? Because if you catch it at a later stage, it's a much different treatment prospect than if you catch it at a very early stage. And unfortunately, especially because folks may have changed their legal sex, sometimes insurance will deny things like sex-based screening, like mammography. So that means that folks may not be getting the screening that they may be at especially high risk for, which is, I think, yet another reason why it's really important to do have that genetic risk conversation and see if a patient is interested in learning their genetic status before having or before getting too far along in terms of whether or not they, choose a surgery type or something like this. So I think, and then we've had patients report like, oh yeah, my doctor told me, like, they were confused about the interview in general because they thought, having had top surgery, that they were at no risk. So at least their interpretation from what the doctor told them was that they had no risk. And whether or not the doctor said you have no risk or your risk is infinitesimally small, or, I don't know what language the doctor used when it's a
Right.
patient report, but whatever the doctor was communicating, it wasn't clear enough to the patient that they still had risk they need to worry about. Like we know, most people aren't having these conversations with their providers in the family health clinic setting. So whether or not they've had these genetic risk conversations, I think tends to be pretty rare. I was the person who brought it up with my own surgeon. And then, even though I actually meet NCCN guidelines for referral to genetic counseling, my particular health system, which is a managed care system, it's like my insurer and my provider, said I didn't meet their internal guidelines for referral. I ended up getting it through a study that I met was using NCCN guidelines as their guide for genetic testing. And that's how I got access to genetic testing, was through a research study that paid me back for the testing. So I think this is like a really important conversation for doctors to be having with their patients, because, we need to find out, can we get them the coverage that they would need to have genetic testing? And to do that, you need to know their detailed family history. So hopefully that they can get genetic counseling to get that detailed history.
Right. And so that was my next question, is thinking about what type of hereditary cancer testing should someone who's transgender or non-binary have? Because you mentioned you did it through research, but are there other considerations to think about?
Yeah, I think, one of the things that we have fortunately moved forward towards in the genetics precision landscape is more panel-like testing, because we know that
Mhm.
syndromic cancers don't always present with sort of the classical phenotype in a family. Meaning you don't necessarily always have two breasts and an ovarian cancer means you have hereditary breast and ovarian cancer. You might have some
Mhm.
of the rarer types of cancers that are less prevalent in the population of individuals with those genetic variants, So we've moved towards more panel testing, such that unless there's a known variant in the family, people tend to get at least a panel of the highest penetrance genes that cause several types of syndromes. But I think some really important considerations are things that may be dysphoric for people and may be difficult for them to move forward with screening for. And they may not necessarily, we already know that there's cancer screening disparities in LGBT populations, and that's probably a mixture of things related to care access, like in terms of having health insurance at any given time, the ability to take off work for screening appointments, things like that, as well as things like the dysphoria those types of intimate experiences may incur. So certainly, we've talked a lot about breast cancer. So certainly for both trans women, I think, and trans men, breast cancer risk assessment is critical. But trans men sometimes have a hysterectomy but retain their ovaries. So it's also important for their ovaries, because that syndrome sort of frequently runs together. But also ovarian cancer can be caused by genes that don't cause breast cancer, and I think vice versa. I think it's
Mhm.
really important to get a full picture of history and hopefully get them access to a panel test that would cover those things. And then endometrial cancer, which is part of Lynch syndrome. Again, hysterectomy is sometimes a gender affirming care choice, and people may choose it earlier than they would have otherwise, but we're going to do so anyway. They just may pursue it earlier than they might have with the knowledge of genetic cancer, or maybe they weren't going to do it because they don't particularly care for the invasiveness of the surgical procedure. And that's not necessarily an aspect of themselves that causes dysphoria. But upon learning their cancer risk information, they may change their mind and go for the surgery, just like a cisgender person would, Similarly, I think prostate exams can
Mhm.
be an intimate experience for
Mhm.
anybody receiving them. I don't think they're comfortable even discussing having a prostate may be difficult for a trans woman. Many people are not out to their usual care providers. They may be only out to a person providing them gender affirming care, and they may intentionally receive that care outside the system. So knowing their risk and finding ways to pursue that, screening for that risk that they are comfortable with pursuing, I think is really important. And so my wife runs a primary care practice here in Vancouver, Washington, but she has some patients who they go to the same managed care system that I go to, but they don't want their
Mhm.
gender affirming care documented in that same system because they're afraid that it will affect the care that they receive from other providers. And so they actually pay an out-of-pocket fee to come see her outside of their own insurance. And so in that case, even if she has that conversation with them, it's not going to necessarily make it back into the medical record. So then they'll be in charge of who interacts with it and how. But, they could arrange, if they wanted to, screening, or they may just adhere better or be more intentional about receiving the screenings that they are recommended, like colonoscopy when they turn 50, and
Mhm. Mhm.
we can't force anyone to do anything, and we shouldn't, regardless of their gender identity. But I do think it helps people take into account everything and make a truly informed consent decision regarding their care, which I think that should be the goal of all care, right? Like that the
Right.
patient is really providing informed consent to anything that happens to them or doesn't happen to them.
You mentioned NCCN and some other guidelines for screening. Are there specific cancer screening guidelines for TGD individuals?
Yes. And well, NCCN now includes some statements about trans folks. They updated their guidelines recently to include that. So that's good. And then there's a few smaller organizations that have included those. Kim and I have built a list of guidelines, and Kim presented this in her JEMF talk for those of anyone who was in the community, genetic counseling community, who attended NSGC. But they actually are they vary widely in their recommendations related to screening
Mhm.
for trans folks and how they might differ from cis folks. And I think that's, again, just as a result of the heterogeneity of this data that we have or don't have and the incompleteness of our data sets with relation to risk for trans folks. And so, but I think that there's guidelines that cover screening for trans folks that don't have risk. And then there's a few, but fewer guidelines that cover screening for folks who have genetic risks. So I think it's important to differentiate between those because the ones that are for folks with genetic risk are usually, just like they are for cisgender people, a lot more aggressive in their approach towards screening, potential recommendations around prevention, like prophylactic surgeries. So
What would you have, or what would you say TGD individuals should know about the medical appointment or genetic counseling appointment that's related to doing the genetic testing? So, what could folks expect to discuss
mm.
or to provide?
Yeah, so I think it's really important to know that the genetic counselor can best provide you guidance if they know what organs you have now and what organs you may have had, and what tissue types you have now and what tissue types you may have had in the past. So if you've had top surgery as a trans masculine person, letting the genetic counselor know that you had breast tissue and that you had standard gender affirming top surgery, which presumably left tissue behind. And you can even tell, or if you know the type of technique, there's several different types of plastic surgery techniques for doing top surgery. There's some where they actually remove the tissue. They actually make a keyhole cut around your nipple and remove the tissue that way. It only works for people with small chests prior to top surgery. So that can affect how much tissue is likely left behind or the ratio of your original tissue that was left behind. Your body habitus can affect things. So letting your genetic counselor know if you can get them the records of your surgery, I think that's even better because the surgeon sometimes takes pretty detailed notes about like how much tissue was removed. They even will weigh the tissue that was removed. And, your genetic counselor may not be able to make a perfect estimate about how much you likely have remaining, but it may give them an idea. And I think it's also important to let them know what organs you have now. So if you are a trans woman and you are taking hormones and have developed natural breast tissue, you should let them know that. And it's important to know what organs may remain that are associated with quote unquote a sex or a sex assigned at birth. And if you happen to be either cis or trans and intersex and you have a mix of those organs, obviously we're not specifically focused on intersex folks here, but I always feel that, especially in this political climate, their own health is at risk as a result of some of the things that are changing, like an insistence on binary sex. And so it's important to report everything that you know about your body with a genetic counselor that you feel safe with, if you are comfortable doing that. Otherwise, report as much as you are comfortable with, but they can give you the best advice the more that they know. The most accurate guidance, the more that they know. And for top surgery, I think I meant to say this before, but transmasculine folks can actually get a masculine reconstructive surgery, just like cisgender women can get a feminine reconstructive surgery after risk reducing mastectomy. There's case reports of this in the literature. It's usually done in combination with the cancer surgeon who does your risk reducing mastectomy and a plastic surgeon who then builds you a masculine chest shape. They even have masculine chest implants. And they actually do this for cisgender men who have to have, like, say they have breast cancer, which cisgender men can get too. They can do chest reconstruction for men as well. So I think it's important to talk to your doctor about what you want and talk to your genetic counselor about what you want and say, like, I want to know my risk, but if you're worried about having the quote unquote concave chest shape from having a risk reducing mastectomy, tell them it's really important to me that if I learn my risk and I learn I'm positive, I only want to learn I'm positive if we can find a way for me to get that type of surgery, because if it's something you don't want to know your risk, if you can't get access to that type of surgery, like, you want to make informed consent to your genetic testing too. So bringing all that information to your genetic counselor about your goals of care, I think, is really helpful. And then I hope our genetic counseling community who might be listening to this podcast are thinking to themselves about how they can do continuing education on this topic, about the options available in their own health system, like what their plastic surgeons are capable of, what types of ways that they can work with their plastic surgeons to offer this, just like they offer reconstruction to cisgender women, because I think that's important. And trans women who have a breast cancer risk, I mean, it may be hugely important to them that they have developed natural breast tissue. And so being able to have a really good conversation about risk and whether or not they want to know and what types of care decisions might be available to them. Maybe it's easier to get the type of coverage they need for reconstruction if they first have a risk reducing mastectomy that removes their newly developed breast tissue, or maybe not newly, but developed breast tissue, and replaces it with implants, just like you would for a cisgender woman. I think, I think finding ways to make those procedures affirming and safe for trans folks in your health system are also really important. One of the things that we always talk about is this sort of heavily pink breast cancer culture, and men and cisgender men report feeling alienated by this type of culture, right? So I think it's really important that we start to think about how do we build a space for people who aren't the majority? How do we build a space for those people to feel comfortable and safe? Because if we don't, then those folks are going to fall through the cracks, and we aren't going to detect their cancer soon. And we're going to have one of those really, negative outcomes like we discussed, that was reported in one of Kim's studies, where, the provider talked about a patient who they had unfortunately lost to cancer because of this. And the consequence could be death of
Yeah.
not having these conversations in a safe space for your patients to share. So
One thing that is challenging is in assessing risk. There are risk calculators. I think
Mhm.
Tyrocuzic, some for breast cancer that I'm familiar with. But they were built without folks who are transgender, gender diverse in mind. How do you think doctors and counselors can do better in this area?
I have so many thoughts. So, I mean, I work closely with my mentor, Sapna Singhal, on PREM, which is a Lynch syndrome counselor. Calculator was PREM 5, but then now we have PREM Plus, and it actually assesses risk for breast cancer as well. But it relies on sex at birth information because the data sets we use to build these have to be extremely large. Like,
Mhm.
I think it's 21,000 people or something that built Prem Plus, so these are very large numbers of data sets. And that's why I was so looking forward to the next era of precision medicine because finally people were starting to collect in these large cohorts of individuals that we were following for long periods of time in research. And in these large registries of patients, we were starting to collect information about hormone use, whether or not they were cis or trans, and including hormone use in cis people too, like for menopause type symptoms. We were getting more and more towards a world where I could see building a cohort of 21,000 trans people to, update Tyrer-Cuzick and some of these other risk calculators. And I so mourn the loss of the ability to do this right now. And I shouldn't have to argue that losing this for trans people will also hurt cis people, but I'm going to because that's where we are right now in the
Right.
moment. And I think that people need to understand that by losing this information, we're also losing key detailed information about every person in a cancer risk cohort that will affect how we make risk calculations for every person going forward,
Mhm.
and especially our trans patients. And so I think it's a massive loss.
Yeah.
I can't even describe to you what we've lost in the future by losing what we're losing now.
Right. Right. So let's talk about that because there is, politicians, states that are actively trying to restrict diversity, equity, inclusion programs. How do you see that political climate impacting research and healthcare for the transgender community?
Well, for starters, we have already seen so many people in my wife's clinic who want to have their insurance billed for their gender affirming care, but they don't want a diagnosis of gender dysphoria on their chart. But those two things are unfortunately incompatible because of the way insurance is set up in this country. It's committing fraud to perform one set of care and bill for another. So, people are truly afraid to be able to be identified as trans in medical data sets, even at their own healthcare provider. And that's because there have been instances. I mean, the Justice Department sought to get records from Boston Children's Hospital just recently. In Tennessee, the Attorney General got a large health center to release records a few years ago, actually, before um, this administration even existed in its current state. So, even at the state level, there are initiatives to seek people's detailed medical information, and people are worried about what will
Mhm.
happen to their medical information, rightfully so, if it gets into the hands of somebody who wants to hurt them or wants to hurt their community. And I think that it's important to recognize that a lot of marginalized communities have become very concerned about the trustworthiness of medical institutions and the government. And historically, we haven't been trustworthy actors. And so I
Right.
don't think they're paranoid personally. I mean, maybe
Mhm.
you'll call me paranoid for saying that, but I don't think it's paranoid to be worried that someone might release health information if sought under a legal proceeding because HIPAA says that for legal, like if something is related to you doing something illegal, like if you have murdered someone and then you tell your doctor you murdered someone and they
Right.
document this, that is not necessarily protected by HIPAA. Unfortunately, if we criminalize people who are trans for being trans or for receiving trans healthcare in the past or in the current time, we could potentially be looking at that. And I understand why people are asking for that. And what that means is it's going to endanger people because they're going to not tell their providers what organs they have necessarily. They're going to further seek to segregate their health care in different health systems. And unfortunately, you know, that will be less possible as time goes on because of 21st century cures, which means we now exchange data between health systems.
Mm-hmm.
And I talked about this at NSGC. And so people who wish to keep this out, I already have heard of instances of people seeking hormone care on the black market, and that's just not safe. Like, it's not
No.
regulated. They may not be getting what they think that they're getting. They may be getting anabolic steroids instead of testosterone, like you might use if you were, doping for sports, and
Mm-hmm.
this is not going to help
Mm-hmm.
anyone whatsoever. And it's going to create so many more, like, sorry, I'm getting emotional because, like, I'm just
Yeah.
thinking about, like, how many people will be hurt. It's not just the withdrawal of care and the, resulting suicidal ideation. I mean, while conservatives have argued, oh, you can't prove gender affirming care is linked to reduction in suicides, we can prove that it is linked to a reduction in suicidality. There are studies now that have shown that it has reduced suicidal ideation. So even if we haven't done long-term longitudinal studies where we withhold hormones for people, we have shown that if you delay giving hormones to people and start people on hormones, the suicidal ideation is impacted. And so I think it's reasonable to conclude that suicides would be impacted. But I understand,
Mm-hmm.
although don't necessarily agree with that from a just common sense water is wet type of perspective. If you reduce
Mm-hmm.
suicidal ideation, one hopes to reduce suicidality. So,
Mm-hmm.
or I mean, sorry, suicide. But even just from like the beyond the psychological perspective, there's this potential for great harm from getting products outside of the guise of a doctor. There's a potential for great harm if somebody doesn't share their organs inventory with a trusted provider and get an accurate cancer risk assessment. There's just so much potential for harm to my community by weaponizing our medical care in this sense. So,
Mm-hmm. I'm sorry that this is happening with, as you put it, the weaponization of medical care. Are there any practical steps that patients could take to better protect their privacy and not sacrifice the quality of care? How can patients get care at this point?
yeah, I think it's hard because there are many states that have completely restricted it for people under 19, right? Because they receive Medicare, Medicaid. So in those cases, there are a lot of states that are, and that was the recent Supreme Court decision that was handed down this summer, was that was perfectly legal for those states to do. And so that means even legal adults are having their care restricted who are 18 and 19 years old. And in those states, you know, there are people who travel out of state to an accepting state, but it's possible that their medical records information could be ported back into their home state if they are on, if they're getting care at a health system that participates in the health information exchange, which is most health systems, at least anyone who uses certified health IT. Now, you can talk about what information is shared with whom and how with your provider, right? If they bill your insurance, they're going to share it to your insurance. And that's the only way many of us can afford this type of care, right, is through our
Mhm.
insurance. So, your insurance will know. And of course, everyone is beholden to the current law in your state, wherever that state may be. So if your state currently protects your data, as long as you stay within that state, you are currently protected. Now, I can't promise you what would happen in the future, and I can't tell you what might happen if you go to another health system out of state because you're traveling and you get in a car accident, for instance. So, if your health system participates in the health information exchange, I don't want to say you should never travel, but, maybe thinking carefully about which states we travel to is a really important thing right now. And you know what? If it slows down the commerce of those states, it makes a tiny dent in them. If more people would join those types of, travel restrictions, I think, to states like that, it would potentially impact things. But, my family's in the South. So if I want to see my family, I'm going to go home. And
Right.
but I know that's a risk I incur. And so I think everybody should just educate themselves on the law. And unfortunately, that means staying up to date with the news, um,
Mhm.
both locally and nationally. And I know that that can be a stressor for many people in marginalized communities to see what's going on in the news. And so sometimes we all just need to disengage for a little bit. But I think, especially before you travel, especially if you live in a safe state, understanding how that works would be important. And I think,
Mhm.
especially if you're going to travel out of state to receive care, if you're in a restrictive state, understanding how your health information might make its way back to your provider in state is important. So I think just like
Mhm.
coming to understand that landscape and talking to any prospective provider that you're going to get care from. Like if you're like, oh, I live in, I don't know, so let's pretend like I know Washington is where I live now is pretty protective of trans health and has historically been so. But let's say Idaho goes there and starts restricting care. If you're in Idaho and you're going to travel to Washington, just understanding if the healthcare provider that you're seeing takes Medicaid and Medicare, they're going to be using certified health IT. And so understanding whether or not that care information may make its way back and understanding what their own policies are about whether or not they would share information from a historical past if care became illegal in the future, I think is reasonable to ask your doctor. Your
Mhm.
doctor may not be able to tell you, but they may be able to direct you to whoever is in charge of legal for a healthcare system. And,
Mhm.
I think it's worth asking the question.
Yeah, definitely. And we'll include some resources in the show notes as well that dives into the legalities to hopefully
Hmm.
help some of the people that are listening. I think then the other side of that question is what can healthcare providers do to protect
Hmm.
privacy of LGBTQIA plus transgender, gender diverse patients?
Yeah. So first, let's speak about this in the genetics context, right? Because, someone may have had top surgery 15 years ago, right? And
Mhm.
now they're seeing you as a genetic counselor. And we talked about this at NSGC in our talk. But one of the things is to remember that ultimately you have a duty of care to your patient, but also a duty of care to your patient's data. Right. So if you are not directly providing them gender affirming care, and you're providing them genetic counseling, say, but knowing their cancer organs matters in terms of your risk assessment, it's worthwhile to ask them. But you have to ask yourself, in what situations does it require me to document that? Can I have it?
Mhm.
And if it does require it, before they start revealing too much, can you stop the conversation and have a conversation about effectively a formed consent for documentation, which sounds absolutely bananas, but it's not because it's in your
Mhm.
consent forms actually when you receive care. But,
Yep.
it's usually like you walk into the office and they say, okay, sign here. It means you consent to receive care and all that comes with it. Okay, who's not going to sign there to get
Right.
emergency health
Right.
care or whatever else? But does your emergency care physician need to write down that you've had top surgery? Like, probably not, unless there's like an imminent risk to like loss of aesthetics or something related to an injury. But most likely not. Does your genetic counselor need to write down that you've had top surgery? I mean, I think only in so much as the person has a risk of cancer and what you estimate that risk of cancer to be. If you need to, and we have done this in systems that I have consulted with in the past, is share information about both cisgender women and cisgender men in the hereditary cancer space because it affects their relatives too. So you can say,
Mhm.
people assigned male at birth have these risks, provided they still have these organs. People assigned female at birth have these risks, provided they still have these organs, right? And so if they have breast tissue, a transgender man who's had gender affirming top surgery has residual breast tissue. You can have that conversation with them face to face and then document it with both people assigned male at birth and people assigned female at birth and all of the organs listed. And, write in your note that that's for their own information and for information they may want to share with their family members. I mean, that's one way to potentially do your due diligence in terms of
Mhm.
documentation of risk while allowing the person to choose which healthcare providers they share the information with about their own risk, as long as you're making sure you have a really careful and informed conversation with that person, and maybe even scheduling follow-up visits with them. I think we all have this dream that, once a patient has been diagnosed with Lynch syndrome or is diagnosed with hereditary breast and ovarian cancer syndrome, that they come back and get updated guidance every couple of
Right.
years. But, I did a paper on this back in 2017 in the Kaiser Permanente Health System here in Washington, Oregon. And, what we found was following up patients for as long as 14 years, I think was the longest in my study that I had data on somebody. Most people aren't coming back to the genetic counselor once they get their initial set of recommendations, even though for everyone,
Yeah.
trans and cis people, the guidelines change. And so
Right.
as we learn new things. So I think, making sure that they plan on coming back to see you to get updated risk information, if it relates to their gender affirming care, is key.
Well, and I appreciate you sharing that, Dr. Mittendorf. I know we have covered quite a bit and there's still more to discuss. But for this podcast episode, what is the one thing that you want the listeners to remember from this conversation today?
I think probably for the providers, informed consent is key. And for patients, like most of your healthcare providers, I would say value your autonomy and value giving you personalized care, or as personalized care as they are able to do. So asking them and probing them to find out if they are someone you feel comfortable with revealing, finding a good provider you do feel comfortable sharing some of your key aspects of your gender affirming care with, who can help you get access to accurate, or at least as accurate as we have, information about risk is really important. And so finding a provider you trust that you can tell, I've had this procedure, I've taken these hormones, here's my family history. Do you think I need to see a genetic counselor about this? Do you think we need to reevaluate my cancer risk? Is really important. I know there's a lot of other things on our healthcare plates right now collectively as a trans community, but, if and when you feel safe, this is an important conversation to have.
Thank you. Thank you for stating that. Thank you for sharing your research, but as well as what you've experienced in this community. And I just appreciate you again taking the time to be with us today.
I had written you such a clinical and scientific set of ideas, and I wound up having a much more personal conversation with you. But I think that's okay. Hopefully, people will appreciate that. And certainly, we can get you. I mean, I've done a lot of work in this area. I have a big library of resources. We can get you some resources to post with this, both for providers and for patients, I think. Kim's ownership at the moment, but, we are working towards at least a start on her JMF project of building this resource. And we have a dream to keep getting this data and keep enhancing these resources for risk conversations with your provider as a trans community. And so I'll give you that link as well. And, people can stay in touch for news about, our research efforts in that domain, because I do feel this is so valuable.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.